to you, and thank you very much for your opportunity. And good morning to all the DNB candidates and Dr. Navneet. Under the chairmanship of Professor Dr. Somshekhar, we at the Manipal Comprehensive Cancer Center, we try to do excellent work for the patients. Over the next 40 to 45 minutes, I'll try to take you through different options, different modalities of treating liver lesions, liver mets, or primary tumors. Now, liver directed therapies. I'm going to take it slow and try to give a detailed explanation. Let us see how long this takes. Even if I finish early, we are going to have plenty of time to clarify all your questions, answer all your questions. Now, on a day-to-day basis in your surgical clinics, when you are working with your consultants in your departments, you see so many people with liver malignancies. It could be a primary or it could be secondaries from a variety of malignancies, although most commonly the ones that we are involved with is colorectal malignancies. The first image on the left-hand side is a solitary lesion within the liver, in the central portion of the liver. Second image is someone with multiple lesions spread throughout the liver in both the lobes. And third image, in the right lobe of the liver, there appears to be an abnormality, but here the problem is there is thrombus in the portal vein. Whereas in these images, there is no thrombus in the portal vein. When we are encountered with this kind of situation, what modality of treatment to go for? We have an armamentarium. It could be alcohol, as Professor Somshekhar mentioned, it could be alcohol ablation, it could be heat ablative therapies such as RFA or microwave, transarterial therapies such as ACE, TARE, and other options. Which one should we go for? How do we, as an interventional radiologist, play a significant role in all our comprehensive care center team? Most commonly, we are encountered with, in the case of liver, either it is a primary, which is HCC, hepatocellular carcinoma, or metastases, as I mentioned, it is colorectal malignant, metastases, or neuroendocrine tumors. Others such as breast, uveal melanoma, and there are different malignancies that we might once in a while encounter with, and we offer treatments. Now, these are the different options that we have. Percutaneous ablation. This is heat therapy. One is microwave ablation. Second is radiofrequency ablation. Chemical ablation is with absolute alcohol. Other option is transarterial therapies, which is transarterial chemoembolization, TACE. Transarterial radioembolization is a commonly used word in India. Selective internal radiotherapy is the word that is used in the Western world. Both are the same. And the next option is portal vein embolization. That is for completion's sake. I'm going to cover that also. Now, what role do we play? Where do we come in the algorithm of the patients who is going to be coming back to us again and again over a period of years for the rest of the life? Initial treatment is absolutely very important. We work so closely in all the teams along with surgical oncology, medical oncology, and radiation oncology. So interventional oncology plays a significant role in the management of these patients. The intention is very, very important. Are we managing this patient initially, someone who has got a single lesion with a curative intent, or are we trying to downstage the tumors, metastases, so that you can go ahead or even cure those metastases or a primary, so that you can go ahead and do a primary resection, be it of the liver tumors or of the colonic tumors, and thereby go ahead with the treatment for chemotherapy for the liver metastases? Or, for example, in HCC, are we doing a bridging therapy so that the tumor doesn't progress while the patient is waiting for a liver transplant? Or if it is too advanced a malignancy, are we offering a palliative therapy? That is what it is based on. How do we diagnose the patients, particularly coming to the liver? Now, the patient, by the time he is referred, he would have had one or the other imaging. He would have identified that the patient probably has a primary, or a colonic malignancy that has spread to the liver. Ultrasound scan must be used as just as a screening tool, and does not necessarily give a comprehensive overview of all the abnormalities that are present in the liver. We can get, it's a simple method. It's a starting screening tool. And even for the follow-up, particularly once the HCCs are treated, or those patients who have cirrhosis and hepatitis B and hepatitis C, they are on a ultrasound surveillance program so that they don't get repeated radiation. That is the role of ultrasound. I hope that is clear. Next, with regard to CT, be it a primary malignancy or secondary to colonic malignancies, the liver lesions, CT is an excellent modality. It is one of the best modalities. The advantages of CT are that the patient, it's quickly in and out. Within a minute or less, the scan is completely done, approximately a minute. It's quick imaging tool. It gives an excellent overview of all the lesions that are in the liver and gives an overview of complete how is the abdomen and pelvis and what is the lesion that are there in the chest, for example, that are covered in the lung bases. It gives an overview of the size, the spread, the number of lesions, what is the involvement of the portal vein, and what is the arterial anatomy, and extrahepatic disease and primary. All that information is available on CT. That's the beauty about CT, and there is no artifacts that come up in the CT. Disadvantages of CT: one is radiation. Two, we need to give iodinated contrast. Patients who have renal failure or their creatinine is more than 1.2, then it becomes a little difficult, but we can IV hydrate them and then do the CT scan. That's okay. MRI plays a significant role both in the cases of primaries and secondaries. If the CT is not clear cut, there might not be a classical findings of either a primary HCC or secondaries on the CT scan, then we are in doubt. Let us say a primary HCC, CT is equivocal, it is difficult to find out, then we go ahead and do a MRI scan. Similarly, same thing for the secondaries also. But the disadvantage of MRI is breathing artifacts, the quality of the MRI scan. It takes much longer, approximately 30 to 40 minutes to get a decent quality MRI scan of the liver, and patient has to breath hold, they can be claustrophobic. All these disadvantages are there. Next is PET scan. As you know, I don't have to overemphasize the importance of PET scan in any malignant patient. Now, with regard to CT imaging, this is a primary HCC. These are the classical findings. When we say arterial phase, look at the aorta. When you look at the scans for your exam purposes also, it is quite bright here. That means this is arterial phase. And we are seeing the arteries, the hepatic artery just coming up. We might be able to see the IVC just because there can be some small reflux, tricuspid regurgitation in elderly patients. We might just about see the IVC. Now look at this. This is portal venous phase. This is a little bit delayed. Usually this is about 10 to 15 seconds after injection of contrast. And this is about 50 seconds after injection of contrast. And a delayed image is anywhere between 70 to 80 seconds after injection of IV contrast. And when we are looking at the liver, you are able to look at the arteries on the arterial phase, portal vein tributaries on the portal venous phase. And the delayed is really not looking for although it is called a venous phase or a delayed phase, we are not really looking at any of the veins here. We are looking for characteristics of the lesion. On the first image, this is a HCC, it's a solitary tumor. You can see intense uptake of contrast, and also you can beautifully see a leading artery that goes to the HCC. That is very classical, and this is useful for us to plan for the TACE or any treatment to super selectively go into that segmental artery. Now, there is something a little bit more detail that you might not need, but for the radiologists, there is early and late arterial phases. So if we do a scan in the early arterial phase, let us say within 10 seconds, if we acquire the image, we might not see a contrast beautifully being taken up by the HCC. So we always advocate late arterial phase. That is what we do. So essentially, in simple terms, arterial phase, the tumor lights up HCC, and on the portal venous phase, see, it is starting to wash out. Rest of the liver is taking up the dye, nicely enhancing compared to the arterial phase. it starts to wash out. And then on the venous phase, the contrast is washed out. Compared to rest of the liver, background of the liver, there is washout. So the classical CT findings of a HCC are arterial phase enhancement and gradual washout on the portal venous phase, and well established washout we need to see on the delayed phase. These are the classical findings. If you answer this, that should be ideal, and if you are aware of this, that should be ideal for you. So this is the appearance of a HCC. What about METs? METs, once you look at it, you will know that they look like METs. It's an once seen, never forgotten kind of appearance. So they don't necessarily take up the dye. They are not hypervascular. Apart from the malignancies that cause hypervascular METs in the liver, such as thyroid or renal tumors, majority of the colonic malignancies are not hypervascular. These are hypovascular. So whichever phase we do, compared to rest of the liver, it is all hypo. No contrast taken up. The periphery rim might have some amount of contrast, but apart from that, they are always hypo. Thus are the imaging differences broadly between HCC and metastases. Now, moving on to management strategies. I'm not going to go into too much of a detail between the etiology and epidemiology of the malignancies, but you know that the colon cancer is the third most common. It's a leading cause of cancer death. 20 to 25% of the patient, quarter of the patients have metastasis at diagnosis, and later on over a period of time, more than half of them will develop malignancies, and as high as 80% over a period of time, if they live long enough, they can develop metastases later on. And again, I'm not going to go into the too much of a detail of etiology and epidemiology of HCC, but the 2 or 3 points that we need to remember is these patients usually have an underlying cirrhotic liver. They might have hepatitis B or hepatitis C and alcohol abuse. Increasingly these days, we are also seeing NASH. That means the liver looks normal, non-alcoholic steatotic hepatitis, but unfortunately these people, for one reason or the other, they come with a tumor. Having said that, they might be good candidates for surgical resection. Now, management of be it a primary liver tumor or metastasis, the best option is surgery. We all know that, and you would want to have a surgical resection and give them a cure. However, unfortunately, in colorectal malignancies particularly, a lot of them might not be suitable for a primary resection, particularly of the metastasis, either because of complex anatomy. I showed you the image. It will depend on the number of lesions, size of the lesions, site of the lesions. You might not want to go resecting quite a lot of the liver. They might have extrahepatic disease at presentation. Their health condition might not allow you to operate on them. And as I mentioned, a lot of them might develop over a 10-year period of time recurrences within the liver. Moving on to what are all the options I briefly summarized previously, let us start off with ablative therapies. Ablative therapies can be either heat ablation, which means we are increasing the temperature in the lesion, that is thermal ablation. Two modalities are available, radio frequency and microwave. The other ablation is cryoablation, where helium and nitrogen gas are used. We don't use it in the liver, we use it in the kidneys, but just for your knowledge, this is where you cool the lesion and thereby result in causing death of the tumor. Essentially, an ice pack is formed within the lesion, that is cryoablation. The third thing is chemical ablation using absolute alcohol. I'll tell you where we use each of them. We are not going to go into cryoablation here. Essentially, it is well established for renal tumors, but we don't really do that much in India. It is available. Thermal ablation, heat ablation is one thing that we need to concentrate on. Indications for ablative therapies, we are looking for either primary, which is HCC, up to 3 lesions and up to 3 centimeters in size. These are what we call small lesions, and the number is also small. Or if it is colorectal mets, we are looking for oligometastatic disease, which means 3 lesions or maximum of 4. That is the size criteria and the number criteria for ablative therapies, be it RFA or microwave. Or if we have a patient who is not suitable for surgery, then we can do ablation. We might do ablation either percutaneously or intraoperatively. I'll discuss all that. What is radiofrequency ablation? Ablative therapies synonymously is the word is used RFA. The reason for that is RFA is the first thing that was introduced from ablation point of view. The difference between radiofrequency and microwave ablation is simply the frequencies that are used. This RFA is approximately 500 kilohertz. I'll come to the microwave, that is megahertz, that is much more frequency. So this is one point. It can be monopolar or bipolar. When we place the antenna or probe into the lesion and start the generator of RFA, the current is induced by these frequencies, and thereby ionic collisions happen within the tumor, causing a thermal heat, cellular damage. Thereby what happens? There is protein coagulation, which is irreversible and damage to the cellular membrane. So essentially we are causing heat-induced necrosis of the tumor. That is RFA. You just have to remember that the frequency is different. That is the main difference between RFA. There's one more difference, I'll come to it, between RFA and microwave. So what is microwave? See, I was telling you it was kilohertz, approximately 500 kilohertz, easy to remember. Here microwave frequency is in megahertz. This is about 1000 to 4000 megahertz. So again the principle is the same. The generators are different, the principles are the same. Now we use a microwave generator for a microwave ablation. Otherwise, the technique is exactly the same. The antennas are different. That's all. The antennas can be, for example, microwave, the antenna could be made of metal or porcelain. Most commonly we use porcelain antenna. And the same thing happens. Again, internal coagulation necrosis and cell membrane damage and irreversible damage to the tumor. So I'm sure you understood the difference between RFA, radiofrequency ablation, and microwave ablation. Some three differences that you have to remember. What is the difference between RFA and microwave ablation? Number one, we told you about the frequencies. Number two, we will need to use the pads for the RFA. I'll show you that. There is one important phenomena called heat sink effect. That is why the radiofrequency microwave ablation has an advantage over RFA. See, this is the antenna or the probe that we are keeping inside the lesion, and we start generating heat. Over a period of time, the central orange or red area gets the maximum heat, and gradually over a period of time it spreads and we get an ablation zone of the tumor. However, let us say the portal vein or hepatic veins are close by to the tumor, then the heat is lost through these blood vessels. That is what is called heat sink effect. The heat is being lost. You are trying to ablate this, but the blood vessel is stealing away the heat. That is more common with radiofrequency ablation, much less common with microwave ablation. So hence microwave ablation gives us a significant advantage for the lesions that are close to the microwave ablation. And there are some more differences. I'll come to it in the next slide. When you refer a patient for ablation, how do we do the procedure? The procedure is performed. I'm saying by now all the workup has happened. The triple phase CT scan and identification, staging, PET scans, everything has completed. And after surgical oncology, we see the patient in the clinic, explain exactly what we are going to do, take informed consent and all that. The procedure, ideally ablation, is done under general anesthesia because we don't want any movement by the patient. And whenever required, we can even give apnea, stop the ventilation. That is the advantage. We perform the procedure under general anesthesia. And this obviously, like any other surgery, requires 6 hours of fasting. The basic blood workup, that is as a bare minimum that is required, is CBC, LFTs, coagulation and renal profile, which you would do anyway. Particularly for ablative therapies, we would want the patient to have IV and antibiotics, 1 dose which is before the procedure and 2 more doses. So which means a total of 3 doses, three doses during their admission, IV antibiotics, and they go home with oral antibiotics. And usually for post-ablative therapies, the patient goes home the very next day. That's the advantage. Now, ablative therapies, be it microwave or radiofrequency, we can do it either ultrasound guided or CT guided or a combination of both. This image, the patient has a lesion, a hypoechoic lesion. It might not be very clear on this image, but the patient, which this we did very recently, he had a solitary HCC. So this is the lesion, and percutaneously, this is towards the head end, this is the foot end, this is the anterior abdominal wall, and this is the deeper abdomen. And this is the liver. You can see the liver capsule nicely. He was a cirrhotic patient. He had a single lesion. This is microwave ablation. The antenna is under ultrasound guidance nicely introduced here. And when we start the ablation, start the generator producing the heat, a nice cloud is formed. You see, whenever you have air in the abdomen, we cannot, or anywhere, we cannot use ultrasound. We cannot see properly deeper structures. This here, the air is being formed. We call this a cloud, and we need approximately 5 to 10 millimeter around the lesion to say that we have had enough good margin, similar to your resection margins. Hence, ablations have been compared to your surgery, very equal efficiency compared to surgery, surgical resection. I'll come to that. So this is the cloud that is being formed. The advantage of microwave ablation, we get ablation zones very quick. For example, 2 to 3 minutes, the procedure is done. However, that depends on the size of lesion. Let us say a 2 centimeter lesion, the procedure itself, the ablation itself, we can complete within 3 minutes, and then we retract the antenna gradually and ablate the tract with the same heat. About 75 watts is used, and for 3 minutes, the procedure is performed. However, rest of it, before and after the procedure, are also equally important, so it takes time. If the lesion is large, we can do overlapping ablations. Now, that is the basic principles of ablation. CT guided, when do we use? For example, look at this lesion. There is, in the epigastric region, the xiphisternum is coming. We are unable to directly visualize. It's going to be technically challenging to visualize the lesion under ultrasound. Then we try to check whether it is possible to see under ultrasound guidance. If it is not possible, then we use CT guidance. You see this hypoechoic, attenuated lesion in the CT scan. One more, the terms that I'm using, let me not confuse you. Echogenicity is ultrasound. Attenuation is for X-rays, hence CT. Intensity, iso-intense, hyper-intense, hypo-intense is for MRI scan. These are the terminologies. So this is a hypo-attenuating lesion in the left lobe of the liver. Under CT guidance, we have placed the antenna, and this is post-ablation. You can see air locules also from the burning. So we should not be confused this on the follow-up imaging. Even if patient has mild fever, let us say 100 or below, we shouldn't confuse this for an infection when the patient comes for the follow-up. So that is just a post-procedure appearance. And these pads, like during your surgery, is required only for RFA. It is not required for microwave ablation. That is CT guided ablation. When we work with someone so very experienced, such as Professor Dr. Somshekhar, where robotic surgeries are offered in Manipal Hospital, we perform procedures. They are able to do robotic resection of the primary malignancies. This patient had a solitary liver lesion, and we are able to introduce the antenna both under ultrasound guidance before any introduction of air and from anteriorly from the chest wall, and through a minor 2 to 3 millimeter incision, we can ablate the lesion completely. Which means, what I'm trying to say here is, intraoperative ablations are also offered during the time of surgery, whether it could be laparoscopic or open or robotic surgeries in specialized centers such as ours. This is a lady who had sigmoid colon tumor. The primary malignancy was operated. At the same time, there were 3 lesions. See, this is very subtle lesion. This is also the liver. This is actually in radiology terms called silver of the liver, because it comes all the way onto the stomach and drapes almost coming towards the spleen. Here in the left lobe of the liver, segment 2, 3 junction, there was 1 lesion, and higher up in segment 8, there was 1 more lesion. Here, 1 more lesion lower down. All the 3 lesions during surgery, we were able to ablate, and the patient has had complete cure of the liver metastasis, and she is being followed up alive even now, 3 years down the line. This procedure we did 3 years ago. What are the differences between microwave ablation and radiofrequency ablation? Microwave ablation, the advantage is higher temperatures, hence shorter ablation time. Higher penetration and the volume of the tumor is covered is bigger. We get a much better spherical ablation. That is why we prefer microwave ablation here in Manipal. Grounding pads are not required in microwave ablation. Heat sink effect is almost negligible or not there in microwave ablation. Contraindications for ablative therapies: when the patient has multiple lesions or uncorrectable coagulopathy, if they have significant ascites that is recurrent and it feels unsafe, or they have a decompensated liver disease or advanced malignancies. These are all the contraindications for ablative therapies. A couple of examples. See, there is a lesion here. This is a CT scan which shows pre-ablation. Post-ablation, complete necrosis, there is no enhancement at all. This is just the normal portal vein coming up there. Here, the tumor has also shrunken in size at 3 years. Again, this is another image of post-ablation, 1 month follow-up and one year follow-up. The central hyperdensity tends to stay for some reason. This is all coagulated proteins and blood that can stay, but this is not tumor. For that reason, we can perform a plain scan to show, even on the plain scan, this is not contrast, to show that there is significant enhancement. We assess response on the follow-up scans based on certain criteria, RECIST criteria and modified RECIST criteria. Immediately when we perform a scan, because of the ablation zone, it can look bigger, and gradually we want reduction of the size and necrosis and no enhancement within the lesion. There are several studies to show that ablation very well established, and RFA or microwave ablations have been almost very well compared to surgical resection. Particularly, they play a very good role in those who are not suitable for surgery. They are similar. The outcomes are similar to surgical resection, particularly if the lesion is 3 centimeters or below. We know from the CLOCK trial that a combination of ablation and chemotherapy, patients have done better than chemotherapy with improvement in overall survival, progression-free survival, and median survival. Now, moving on to transarterial therapies. I think I've got another 15 minutes. I'll finish this. Transarterial therapies are TACE and TARE and hepatic artery infusion, hepatic arterial infusion catheters. Now, that's just an image to show how a TACE is performed. We come from the groin, from the femoral artery, cannulate the celiac axis, selectively go into the hepatic, and this is a catheter placed. This is the tumor bed, and we inject the medicine, whichever that is. I'll tell you what we use. The advantages of TACE compared to chemotherapy, systemic chemotherapy, is that we manage to instill much higher doses into the tumor bed. There is reduction of systemic side effects, and there is a combination of chemotherapy and ischemia. Although we don't induce necessarily ischemia, we still want the forward flow because there are negative effects from ischemia. There is a combination of all these effects, and TACE definitely instills much higher dose into the tumor bed than a systemic chemotherapy. What are the indications? Be it primary HCC or metastatic disease, when the patient is not suitable for ablation, whether it is in a difficult territory or the patient is not suitable for GA, oligometastatic disease, or patients have multiple either metastases or multiple lesions, bilobar or unilobar HCCs. Patient not suitable for surgery, or when there is, particularly in metastasis, there is disease progression or toxicity to systemic chemotherapy. When we say disease progression or failed second-line chemotherapy in colorectal metastasis, for example, those are the indications for transarterial. So this I have covered. How do we do the procedure? Majority of the times we do the procedure under local anesthesia for HCCs, particularly when we are giving irinotecan, Deberry. We have to have the anesthetist present because this drug irritates the liver quite a lot, and the patients can have quite a lot of pain during the procedure. Hence, we also use Xylocard intraarterial. So, local anesthetic. It works really, really well. The patients can be discharged. The protocol is the same for IV antibiotics and oral antibiotics. The patient can be discharged either the next day or second day after the procedure. This procedure performed through the femoral artery. A simple 5 French or 6 French sheath is placed in the groin artery. Selective cannulation of the celiac axis through or a SMA when there is repressed right hepatic with a cobra shaped catheter or a reversed SIM catheter. A further coaxial technique, we place a micro catheter, a very, very small catheter through this mother catheter, and then we get into the specific artery. See, after injection, we have the tumor highlighting there, and we inject the material. Now, what are the different types of TACE? The first thing that was introduced was C-TACE, conventional TACE, before introduction of the DC beads, where a lipidol, which is a ethiodized oil, it's a plant extract, that is mixed with doxorubicin in case of HCC, and that oil gets deposited. This is on the follow-up scan. You can see that hyper dense material, that is the oil. So doxorubicin mixed with lipidol is called conventional TACE. That was the first to be introduced for TACE. Next is DC beads. This is how the DC beads look when they come from the company. They come from in variety of sizes. Most commonly used is these two, 100 to 300 micron size or 70 to 150 micron size. This blue color, you know, doxorubicin is red in color. After mixing with doxorubicin powder, in 45 minutes approximately, that is the standing time, they become red in color. Whereas when irinotecan is mixed with DC beads, it turns into turquoise blue. That is the difference. Irinotecan, when it is mixed with DC beads, drug-eluting beads, TACE. When doxorubicin is mixed with drug-eluting beads, which is DC beads is just a company, drug-eluting beads, it's called DebDox in the terminology, oncology terminology. When irinotecan is mixed with the same DC beads, it is called Debiri. These you need to be aware. Now, a tumor that is lighting up, depending upon whether it is, this is a primary HCC, depending upon if it is HCC, we use DebDox. If it is colorectal mets, we use Debiri. That is the simple difference. Dosage, if the patient, it will depend on the bilirubin levels, whether we are doing a segmental TACE, which means we are going selectively or super selectively into each segment, or whether the patient has multiple lesions, we do a lobar therapy. Obviously, it depends on number of lesions. If the patient's bilirubin is less than 1.2, then we try to give full dose, which is 100 milligram. Irinotecan is the same, 100 milligram. However, there is one catch. Each vial, we can only load 75 milligrams of doxorubicin. We don't go more than that, because effectivity again will be lost. It might not, the DC beads might not take up the full dose. So each DC bead vial, why are these procedures costly? This vial of DC beads costs about 65 to 70,000 rupees. That's why it is. And the microcatheters are costly. That's why the procedures become costly. However, just leaning on to the clinical bit, if the bilirubin is more than 1.2 and below 2, we just give half the dose. 50 milligram, we do not go more than that. Irinotecan is the same, elderly patients, and where we want to be extra careful. And if their bilirubin is more than 1.2, again we divide this dose into 50 milligram. Now, if the patient has bilobar problem, we do a lobar therapy. If there are very few lesions, we go into the segments and instill the medicine directly so that the tumor gets the best possible dose. However, if the patient presents with bilobar, multiple mets in both lobes, we do the right lobe, for example, now and instill the dose. We don't touch the left lobe. 2 to 3 weeks later, when the patient has recovered, we do the left lobe and then call the patient for CT. If it is only single treatment, we perform a CT scan, follow-up scan at 4 weeks. So this is what is segmental if there is a single lesion, and this is lobar treatment. When there are multiple lesions, we just enter the lobar artery and directly from there we inject. What are the positive predictors for TACE? When there is limited size of the lesion, hypervascular lesions are very useful because the drug gets to the tumor very well. On the post imaging, follow-up imaging with excellent necrosis and the tumor response is good. These are all positive predictors. Negative predictors, high volume tumors, low vascular appearance during the contrast injection, both on CT and angiography, incomplete necrosis with residual tumors, and progression on the follow-up. These are all negative predictors. This is an example of a patient with HCC, arterial phase. There is enhancing lesion. And this is again arterial phase. On the follow-up, there is no enhancement. At follow-up, this is complete response. Again, another example where there is huge tumors before, and this is immediately after the treatment. There is no further flow within the blood vessels. At follow-up, there are large areas of necrosis, but that is fine. That is good. So this is another example of HCC pre and post TACE. These necrotic areas, we are not too worried as long as the liver function, see, rest of the liver is normal, as long as the liver function remains normal. There is also for large tumors that are going up to about 5 to 6 centimeters, we use combined TACE and ablation at the same time. The advantage is that it has a synergistic effect. There is improved lesion response. The central portion is ablated. The peripheral portion gets the TACE. So this is another case of combined TACE where centrally the ablation has happened and peripherally C-TACE has been performed. The peripherally TACE, the doxorubicin is taken up. There are multiple studies proving the efficiency of TACE. Now, what do we do when there is portal vein thrombus? I think I should finish in a minute or two. When there is portal vein thrombus, this patient is not suitable for TACE. This is not good because we are occluding the hepatic artery. These are the typical cases that are useful, that are suitable for TARE or CERT. What is exactly done during TARE? It is done in 2 stages. Step 1, we are trying to assess the lung shunt. Hepatic angiogram is performed. Technetium-99 macroalbumin aggregates are injected. Then they go down to nuclear medicine. Under a gamma camera, we assess how much is going into the liver, how much is going into the lung. As long as the uptake into the lung is less than 20%, we can go ahead and perform TARE. We then order the drug, which either comes from Singapore or Canada, depending upon the company. We calculate the tumor volumes, and the following week, once the drug is available, the patient is scheduled for the same hepatic angiogram and Y90 injection. It is injected into the same planned, previously injected technetium-99 artery, be it segmental or lobar. Majority of the times, TARE is performed lobar. The advantages are that the patient gets high dose internal radiation. These are microspheres. The ischemic effects are much lesser. Depending upon the company, it could be, if it is TheraSpheres, it is resin, and Cerspheres is glass. It is other way around actually, sorry. And they show very, very good response. And we know from TARE, the median survival is improved. See here, TheraSpheres is actually glass microspheres. Cerspheres is resin microspheres. That is the main difference. We most commonly use Cerspheres. These come from Singapore. Up to 3 GBQ dose selective internal radiotherapy can be given. This is an example of pre-CERT at 3-month follow-up, post-CERT. Contraindications for CERT are high bilirubin levels, coagulopathy, and as already mentioned, the ascites and advanced malignancies. Very, very important to choose the patient. Their echo performance status has to be good. Anything more than 2, we do not offer these treatments. Follow-up on the CT scan, we strictly follow the modified RECIST criteria. We are looking for complete response versus partial response, or stable disease or progressive disease. That is how we report on the CT scans. Portal vein embolization. If you get a patient with colonic malignancy with right lobe mets, the left lobe is completely free and the left lobe is small, you want us to embolize the portal vein and thereby increasing the volume of the future liver remnant. So this is a portal venogram cannulated from the right side itself. And once we do the portal venography, this is occluded with a plug and a combination of glue. This is histoacryl glue. On the CT scan, this is the Amplatzer vascular plug. It's a embolic agent. And the glue, this is how it appears. This is again lipidol mixed with glue. That is why you see it as hyperdense. FLR, which was this, would grow into this. In a normal patient, if it is 30%, we are happy. If it is a cirrhotic patient, it should be 40% at least. This is the summary slide. Alcohol, I have not gone too much into it because it is a simple injection of absolute alcohol. If it is 1 centimeter approximately, 1 or 2 lesions, we can inject alcohol directly under ultrasound or CT guidance. Very cost effective, but infrequently performed because it's very rare that we get the lesions of this size. Radio frequency ablation, same thing for both microwave and radio frequency, or the criteria and size criteria. These are curative procedures, but heat sink is more with radio frequency or significant with radio frequency. The cost is relatively higher with microwave ablation. TACE and TARE very similar, except that when there is portal vein thrombus, we want to go for TARE. Repeat procedures is very much possible with TACE. Cost is more with TARE. You will also need segmental anatomy. I think I might be running over time. I want to give you the last 10 minutes. Segmental anatomy is based on the right hepatic vein, middle hepatic vein, and left hepatic vein. So when we are above the portal vein, this is segment 2, segment 4, segment 8, segment 7. It's very easy actually. You go to your radiologist and learn this anatomy. It's very important. Below the portal vein, segment 3, 4B, 5, and 6. It's very, very easy. CT segmental anatomy is very, very easy. So in summary, this is the management of HCC or colorectal tumors, surgical resection or a liver transplant or the definitive management. These are the interventional radiology options. In combination with chemotherapy or sometimes SBRT is used. TACE and ablation are very, very well established and widely performed procedures. Also, you need to be very well aware of the BCLC classification and management of HCC. So I have summarized and what is the role of interventional radiologist. We work very closely in our Manipal Comprehensive Center under the leadership of Professor Dr. Somshekhar. I wish to thank him and thank the whole of our team, and I'm happy to answer your questions. Thank you.
Reddy, that's a fantastic talk you gave. Amazingly, very, very good talk. Amazingly, very good talk. No better way to summarize the whole thing sequence as you have done. You really exceeded my expectation the way I wanted. Can you open the Q&A and chat box and check questions in both and answer them, please?
Sir, thank you very much, sir. I will. So I think we have one question here on the chat box. If I'm not missing others, I don't think. How to differentiate multiple cysts versus metastasis? It's a good question. First, we start off with ultrasound screening. Cysts are classical appearance of hypoechoic lesions on ultrasound, and on CT they are hypodense lesions. It's all hypo. Whereas metastases, unless there is central necrosis, they are not hypo on ultrasound. Very, very rarely cystic metastasis, those are rare. Most common colorectal metastases, they are hyperechoic lesions on ultrasound, which means they are compared to the rest of the liver, they look white. And on the CT, we have some amount of peripheral enhancement. It's only the central portion, or majority can be hypo, but again, usually we have a peripheral rim of enhancement on the metastases. That's how we differentiate.
In Q&A box also there are some questions. One of them is, what modality can we use for colorectal mats that is very close and abutting porta? Means if you are at a vital organ, as Reddy told, ablative technique with RFA microwave needs to be tailor-made. But sometimes even if they are close to porta, but there is a thin rim of tissue with the vital organ, when they open the microwave, one of the electrode you can make it inactive and burn the other part and handle that. But with microwave, managing the lesions close to vital structure is also easy. But having said that, Dr. Reddy, if you think you don't have a safe distance from the vital structure, say IVC or porta, then what modality would you suggest in that case?
Majority of the time, we have no concern about the hepatic vein or portal vein, as long as the antenna can, or the probe can reach the lesion, the central portion of the lesion. There is no concern about, and as long as we don't go through the vessel. See, we have 360 degrees in a circle, and that is the number of directions we can take to reach the lesion. So the most important thing is we want to reach the lesion not through a vessel. A lesion that is close to the vessel is fine. We choose microwave ablation, and apart from the heat sink effect, there is no concern. However, if someone has biliary dilatation, we have to be careful. The heat damage to the bile ducts can happen, and that's not a good idea, and they can develop biomass. Vessels, it's not a problem. Second question regarding IVC, particularly the caudate lobe, it's a concern. The lesions in caudate lobe are a concern, but it is not a contraindication. As long as the lesions are small enough and we can get to the caudate lobe, long axis, and heat sink is the only issue. There's no problem. It's not going to burn the IVC wall. So that, I think that answers the vascular proximity to the lesion. And I now managed to open the Q&A box. How far lesion should be from the liver capsule from percutaneous techniques? Ideally, within the liver, see, we want to get at least 10 millimeter good ablative zone to prevent recurrence. Whereas subcapsular lesion is not a contraindication for ablative therapies. As long as there is no significant established cirrhosis and access issues, we choose a long track. We are not going through the lesion. We choose a long track away from, so exactly at 90 degrees to the lesion, away from the capsule, we can access the lesion. And when we start burning or ablating, the capsule retracts. It's not a problem. So subcapsular lesions, as long as we access tangentially from the other side, there's absolutely no problem. In a subcapsular lesion, we don't go through the capsule exactly where the lesion is. We don't do that because you have to have a nice track, ablate the track to prevent bleeding complications also, and also tumor seeding, which is very rare. Next question is how to follow up the liver post RFA, what imaging to do and how frequent to do. With regard to any post procedure imaging follow up, whatever the patient had prior to the procedure, majority of the times it is a CT scan, and we prefer the same CT follow up, and usually we perform the procedure anyway. Immediately after RFA, I would perform a CT scan to make sure that we had good enough ablation. But usually our protocol is in TACE or RFA, we do it at 4 weeks, as long as the patient's treatment is completed from ablative or TACE point of view. When it is TARE or CERT, we do it at 3 months. And then what imaging to do and how frequently to do. The first imaging is at 1 month, as I mentioned. And if there is any concern, then we do it at 3 months. Otherwise, we leave it for 6 months and then at a year. And then we can just do an annual follow-up either by CT scan or ultrasound, depending upon the number of lesions. If it was a solitary lesion or 2 lesions, easily we can follow up with ultrasound after 1 year. Next question is, in which scenario there is role of TACE followed by surgery? I think during the talk, I answered the questions. Let us say, particularly you're asking about TACE. Following surgery, if it is oligometastasis or oligoprimary disease, and the lesions, mainly for metastasis, I think you're asking, if the lesions are accessible for RFA and the lesions are few, we do RFA during surgery or immediately after surgery. For TACE, if the lesions are inaccessible, then we go ahead and do TACE. Or if the lesions are multiple and bilobar, we do sequential TACE after surgery. Once the patient has recovered, as soon as 3 weeks. Recently we performed on an elderly gentleman following colonic resection and anastomosis as early as 3 to 4 weeks once the patient is well. That is where the performance status comes.
Also, the another thing is, suppose you have a disease with bilobar mats and you are going to do a stage surgery. Like one part of the liver you're doing and colorectal, there is an inadvertent delay in addressing the second case. Or, for example, they're bilobar at presentation. So at presentation, you can't encompass all of them in one liver resection. And patient is also going on a neoadjuvant chemo, because we know in colorectal we would then start chemo or Erbitux or bevacizumab based on their KRAS status. Then the chemo has a regime, you start with 3 and there is an inadvertent delay in addressing the liver therapy. Then to buy a time bridging in between, then we do a TACE without embolizing or blocking, keeping the vessels patent. So there is some liver directed therapy, they don't increase. And then you go in for liver surgery. So I also use it as a bridging between the neoadjuvant chemo given by medical oncologist. And if there is a delay in addressing the liver surgeon, then we do a TACE and we continue with chemo and then we do it. So sort of then there is some therapy liver directed we have done. So the lesions are stable or they respond.
Yes, sir. Thank you. Yes, sir. Next question is how to manage bleeding during intervention. First, I think the question is more towards ablation. Important thing is to prevent bleeding, and then if at all it happens, then how to manage the bleeding. If we do a nice track ablation, following you choose a good pathway to avoid the major vessels. You're not going through the hepatic vein or portal vein or any hepatic artery. You choose a peripheral access and go into the lesion. And once we do a nice track ablation and come out, once you do that, you do a CT angiogram and confirm that there is no active bleeding, there is no perihepatic fluid, and you are comfortable, then the risk of bleeding is very, very rare. But let us say the patient bleeds post ablation during that day. That is why we have to follow up the patient very, very closely during the first 4 to 6 hours. Pulse and blood pressure monitoring is very important. If the patient has bleeding, unfortunately, then we have to go in and do, like any other bleeding case, hepatic artery super selective embolization with a coil. That is what we would do. TACE follow. Yes, sir.
Yeah, please go ahead.
TACE followed by portal vein embolization, time duration between them. Usually it is approximately 2 weeks. We give that time. It can be variable 2 to 4 weeks, but 2 weeks is sufficient. Post TACE, we can go ahead and do a portal vein embolization when a surgical resection is planned, particularly for large tumors. Sir.
Super. Reddy, for the benefit of students, of the two air, the TheraSphere atrium, which is a glass beads, and the TheraSphere nodules, of the two, which is more friendly if portal vein thrombus is there? Because the moment there is a portal vein thrombus, they all become child's B and going to C. Same rules which apply to surgery apply to ablative technique, because ultimately ablative technique are mini surgeries like RFA and micro. But then TACE is in general contraindicated when you have a portal vein embolism, because then the liver is supplied only by artery, and going through that, and if some problem happens, then liver is devoid of any blood supply. So we then use atrium. So after two atrium, TheraSphere, which is a glass beads, and TheraSphere, which do you prefer when there is a portal vein thrombus, and why?
Sir, both the efficiency, the outcomes, they're both very similar because there is no significant difference. It is just that the make is different. The outcomes are very similar. Availability for us, being in India, TheraSpheres are much more readily available. They come from Singapore. If it has to be TheraSpheres, it has to come all the way from Canada, and their logistics, there is a delay. It is not that they are not available, they are also available. We are much more used to, and TheraSpheres came a bit early and they became more popular. Apart from that, there is no significant difference in the management or the outcome. They are very similar, TheraSpheres and TheraSpheres.
Thank you very much. I think pretty much you answered everything on Q&A and both the chat box. Beautifully you covered it. This is recorded, will go to YouTube and they can re-refer. Wholeheartedly, I thanks Reddy for taking time and beautifully covered, because I know you're always crisp, clear, to the point, no ambiguity, which students need, especially coming week they have exams. Thank you very much on behalf of students and DNB and National Board. I really thank you very much. Wholehearted appreciation and our wishes and regards to you. Beautifully done, fantastically covered, very clear.
I want to thank you, sir. I want to thank you for a couple of reasons, not just for the opportunity to be able to teach the DNB surgical oncology students. It is very important in such a large team for us, interventional radiologists, to be able to work with a surgical oncologist like you, who knows, I just wonder sometimes, not sometimes, majority of the times, you need the treatment protocols you already know. When you are referring the patient, you are so very well versed with all this, your extensive knowledge, it becomes so much easier for us. A lot of the places would be hunting what to do, how to do, which patients to choose and all these things. Your protocols are so very well designed and we just simply fit into it, I feel. It makes our life also easier working with you. Thank you so much. It's an honor to be with you.
Thank you. Pleasure is ours. Thank you very much. Over to you, Navneet Singh ji.
Thank you very much, Dr. Reddy Prasad, for the presentation, and thank you very much, Professor Dr. Somashekhar, for joining us. And thank you, trainees and faculty members, for joining us.
Thank you. All of you stay safe, protect yourself. Bye.
Thank you all. Bye-bye.